Laboratories, BSc Medical Sciences, Bachelor of Medicine, Bachelor of Surgery, Fellow of the College of Pathologists, CMSA, M.Med, Anatomical Pathology, and today he's going to present a critical topic, clinical information in pathology request. Let's raise the roof for our pathologist.
Thank you very much. Good evening, colleagues, and once again, one example, it's always an honor to be invited to this kind of gatherings and stand before you colleagues and share some few things that we normally see, that some of you can see. But before I carry on, I can promise that my presentation is going to be exactly 20 minutes. I'm going to spend 5 minutes on one slide that is very close to my heart. But before I start, Dr. Pufa, I'm not sure if she's still here. Can you please just come closer? Because of your support, colleagues, and the growth that you have enhanced within the practice, I would love to officially introduce you to a new kid on the block, my new microbiologist that started with us in January, and she successfully launched the new lab last week. So this is the second week. So we are growing because of your support, and as you can also see, is a black child that also has an interest in making sure that the health of the subjects in the province is actually taken care of. So Dr. Pofa Tabiso will be with us up until I take my retirement. She will take over from there once I retire. She is a microbiologist from the Gauteng region, so she is now full-time in Limpopo. Tomorrow she's going to present one of her topics, so please take care of her like you took care of me. You raised me, and this is a new challenge, and we'll love to see your support once more. Thank you very much. Right, so colleagues, I think we all know that we like it or not, medical errors are speedily becoming to bring tremendous attention. And it's a bitter fact to all of us that we know that litigation is either at your doorstep of your practice or it's already on your examination bench. I see this almost every month, where we get a lot of queries from HPSA, and we get patients asking questions deeper as to what the doctor requested in the examination and what information was given to us in the test request that was sent to us. So this is becoming a thorny issue, and I think we need to protect each other by identifying these problems and bringing them on board. So I'm going to go through that. It's 12 slides, so they're very quick, to discuss critical clinical information and the significance of it in all pathology requests. And I'll give you some examples and run through my slides very quickly. I'll get stuck on one slide for 5 minutes. Historically, we used to rely on analytical processes. And we used to say laboratory quality was determined by the accuracy of what is happening in the lab. We have got pre-analytical, which is what is happening, the processes that are happening before the sample can be processed within the lab. Once it's been processed, it's called analytical process. Post-analytical is when the results have been printed and reaching your offices for interpretation, and you give them a significant test, whether they fit your clinical diagnosis or your clinical differential diagnosis. However, research has shown in recent times that following the development of high-quality analytical techniques and improved skill development, we are training more techs and we are giving more education, and all this CPD kind of process that also happen in Smarter. So that level of analytical processing has reduced the errors. And it has been identified that pre-analytical processes have got an average of 68.2% contribution to the errors, almost 70%. And that information, it includes clinical information, further information that is required on the reports, on the request forms. And insufficient, incorrect, or illegible data on laboratory request forms a delay in communication of important clinical findings. So I'm going to go through this very quickly. What is very important in this slide is what we don't normally get. I can tell you, colleagues, I found cases. I was talking to one of my friends outside. When I said, I'm going to present on clinical information and request form, he said, hey, that one we're not doing. So I think we all know, we'll pinch ourselves very hard, and we'll go back and revise and review. The requests that we are getting are not having enough information, even the patient data. I had one case recently, name L, surname. Initially it's the L and the surname. No sign of the biopsy where it is taken, nothing. Medical aid is written at least with a medical aid number. I only saw it microscopically, this is coming from the cervix. And I then began to look for the doctor and called him to find more information. So that delays the information that we're supposed to be giving it to you. That delays the reporting of the case. So that information is very critical. So please, if you can just do me a favor and do a favor for yourselves. When we go for litigation, I need to be protecting you. And you need to also be protecting yourself. Patient name, surname, ID and age, as well as gender and location where they're staying is extremely important. Followed by, if you are taking a tissue, I know breast lump. What is your feeling? Is it a fibroadenoma or you're thinking of a malignancy? I'm going to give you the diagnosis, but it's easier for you if it happens that we file these documents. If it happens that me and you have to meet at the High Court, we need to be able to be congruent with each other. So it's very important to also write collection time and date. Very important, because some tests, we can't rely on the results because the collection was actually a few days ago. And remember, I always tell colleagues that results should be taken as a product of a scientific experiment. Without clinical information, it is completely useless. It's up to you when I give you the report to go further and do a significant test. This UNE is fitting to this patient. But with that, without the clinical information, we have issues in releasing some of these results. So clinical, it's very important for you to also put clinical diagnosis or differential diagnosis. Very important. The next slide is going to show you why drug history is very important. I went through some search and found this article, very interesting. Several authors, South African Medical Journal, not very old, 2009, indicated the impact of drugs on a thyroid function test. And I found very commonly used drugs. I mean, if you look at what the cardiologist was explaining now, I'm sure he's still working there. The last one, decrease in T4, 5-dehydrogenase activity, beta-adrenergic. We have some patients that are on TB treatment, rifampicin. That increases hepatic metabolism of T4. You need to be able to inform us, patient on TB treatment, you are doing this investigation, for example, TSH, or maybe we're looking for T4, T3. So give us this information that we can be able to correctly analyze your sample and give you the results. Now, the impact of incomplete or incorrect clinical information, delay in critical results, effective patient management care, it affects that, quality assurance, cost effectiveness, health and safety. Very quickly, critical diagnosis. This is defined as a result that are suggesting that the patient is in imminent danger unless appropriate therapy is initiated promptly. These are cases like, for example, I need to call you and say, you've got a Halley's cyst. This patient is probably going to go into anaphylactic shock. Please treat the patient urgently. Secondly, the current problem now. We are all heroes because we were put in the front line, and I think we need to thank ourselves that our gods and the God, the Almighty, and Allah, and so on and so on, led us to be still alive today. So we need to communicate also SARS-CoV results. These are critical diagnoses. Choriocarcinoma. I had one patient from the public sector when I was still processing histopathologist samples from Mahlakwane Hospital. Young female patient, obviously a very gentle soul. Uterine evacuation performed. I see the specimen. My diagnosis is choriocarcinoma. No address on the form. Nothing. No contact number. Nothing. It's only the name of the doctor with no phone number. Now you know in the public sector, someone is working today, tomorrow they're changing, they're in gynae, tomorrow they're in medical ward, and you won't find them anywhere. So I end up calling the CO and told the CO, listen, this patient, wherever she is probably dying. Choriocarcinoma is one of those diagnoses that the patient will bring you a bunch of roses tomorrow. Today you diagnose them choriocarcinoma, tomorrow they bring you a bunch of roses because it reacts very quickly to chemotherapy. And it is actually an aggressive disease if you don't immediately attend to it. So I said to him, please find this patient, the patient was from Beresford area. Please find this patient and make sure that is brought back to Mahlakwane to get chemo. This patient has got a chance of survival. Unfortunately, the following day I was called. The patient is demised. So this is something that if you don't put that information, we won't be able to assist these patients. For example, we always call for abnormal biochemical results, and so on and so on. Effective patient care. Remember, what you give me, I must be able to interrogate it and assess it, to also look at my investigational strategies. I got a case last week, neck mass. I look at it histologically, I find metastatic adenocarcinoma, colorectal type of morphology. I call the doctor, not available, probably we're all busy during the day. I call later in the evening, not available. Tomorrow I call, I'm told, patient has just completed chemotherapy for a colorectal malignancy. Now this probably is a MET. So I say, normally if I have that kind of a case, it takes about 6-7 immunohistochemical stains to get a diagnosis, and each immunos over 800 rand, I'm way beyond 4,000 rand. Had I got that information before I requested immunos on the very same day, I would have used only 3 immunos as confirmatory. Now it also impacts on us because the medical aid is going to get exhausted. We always say in December, November and October, our patients are forgetting to get ill. And we don't remember that it is us also that are having an impact in it because we don't do things to save these costs for these patients so that we can be able to introduce other modalities. Very important. I had a patient in terms of quality assurance about 2 months ago. This patient, young male patient, 35 years of age, this patient had critical signs of a prolactinoma, pituitary adenoma, seen by one of the very good GPs. I've been working with him for quite some time. This patient is presenting with progressive loss of vision, gynecomastia, loss of libido. These are clinical cases of prolactin, high prolactin levels. He sends the blood, prolactin levels. That patient, the prolactin levels were extremely elevated. Now, when you have got a patient like that, we have been taught, in the past, we used to titrate when you've got extremely high levels. Now we no longer titrate. If you look on the form of Lancet, there's somewhere else written macroprolactin. Those are patients that fit that criteria. We can't titrate, you have to do macroprolactin, and this is an underway test. So had we got that information, we would have immediately said, we can't test this, we are reducing waste, time on the bench, we are saving the patient's money, because the patients cannot be double billed. Let's call the doctor. Can we please request a macroprolactin instead of prolactin levels? Then me and you are having this communication. So it's very important. But remember, you can't have that communication with the tech, especially in small tech labs. Cost effectiveness. We have to reduce the unnecessary workload, increase the turnaround time. If I find you early, if I miss something on the form, it's better, it's good. But if I can't get you, I have to wait on the sample and we do what we call bench staining up until the next day. And also, I've spoken about the medical insurance. Health and safety. I had a patient last year that came through from also one of the GPs. The critical clinical information was query hemophilia, because there's a hemophilia history in the family. Patient comes in, we bleed. In the evening I get called, because my phone is forever on, I get called. Listen, there's a patient that is in the lab and the mother is very, very angry. Lucky enough they're from Sishio, it's not very far. The mother is very angry that a nurse who bled this patient caused damage and the child is bleeding into the soft tissues. Woke up, went to the hospital, we got there, and went to the lab. When I got there, I asked him further questions, any history of bleeding. I'm told that elder brother is having hematorosis, is bleeding into the joints. And they went to the doctor to be investigated further. They were about to be referred to a pediatrician, but then there were some tests that should be done first. So had we got that information, the approach would have been different. So I had to come in and say, listen, we never got the information, then I have to now protect you and say, I'll take the costs. So I took this patient to one of the hospitals in Mahlakwane. They stayed there for about 3 days. The pediatrician managed it, and by grace, the child went back home safe without any problem. So these are examples of why this information is very important. Now let's go to the solutions very quickly.
9 minutes.
9 minutes, good. 5 minutes is going to be here, and then I'm done. Solutions, very important. Remember I said, the tests that we perform in the lab, the products which are results, are just a product of what we call a scientific experiment. You have to put a significant test to it. And no system is perfect in this world. There is somewhere where the system is going to be not giving you what you are requesting. Remember, the error rate in most of the labs is 5%. Because you can find a patient who is having a creatinine of about 160, but not needing any dialysis. Those are the patients that I'm saying are falling under 5%. Extremely high creatinine. Can the patient just had a bra yesterday and happened to have flu and came to you the next day, or COVID, and they're suppressed too much, and then they want to also do UNE. You happen to find a creatinine that is high. So if you try and manage it, so that's why I'm saying you need to put a significant test. So because of compliance with good clinical practice code and ethics, we need to ensure that, because we comply, we ensure that relevant clinical information is completed before we dispatch the samples. Secondly, compliance on my part, or on the part of laboratory medicine, good laboratory practice code, internal audits, interlab correlation, and standards accreditation. When Dr. Mbe was speaking, he mentioned many times when he was showing you instruments about accreditation. I think it's high time that we need to be able to encourage respect to our clients. Running a lab is not like pulling a machine somewhere on the corridors and putting it in a double garage and printing results is a very, very dangerous terrain. It's like an ultrasound if it's found in the wrong hands. I've seen people pulling machines in the back doors and putting them in the garages, testing UNE and everything. Scenarios are as follows. Remember, a ruler is one example of an imperfect item in the world, whereby they try to perfect many times and they're still failing. If you take a ruler, it's having many lines, marks. What happens if what you are measuring falls between the marks? Now you need expert advice. If we happen to be in court, my brother, my sister, tomorrow, and the judge asks you, have you discussed the results with the person that tested this patient? Your answer would be yes. The second question would be, who is that person? Is Mr. So-and-so. Qualifications, medical technologist. Now, you need to now start thinking, how is going to be your level of qualification compared with the level of qualification for a medical technologist? How are you going to get advice from a medical technologist when you are a doctor? That becomes a big problem. We have been having a lot of questions coming out. Remember, when I talk about compliance, we can give you the results, but we need to make sure within the practice, if you are accredited, that every level of testing need to comply, and you must have process that you implement to guide the results. In Lancet, we've got what we call rebel down. Any form of error that occurs is being picked up by the machines, and it's also being picked up by our system, LIS. Then from there, we don't release the results until we are sure these results can be able to be tested and can be able to be reproduced. Now, in the medtech labs, the small tech labs, what happens? They get the QC done by the suppliers. It's a dumping zone, production zone. They just dump them there. We have a QC of over 2 years. We don't do anything within 2 years. We keep to one reagent. Anything that changes, we send it back. They must pay us our money. So it's very important that you need to guard yourself with the right areas. So that's why I said I'm going to spend a lot of time here. And lastly, medical electronic systems. Guys, IT is growing and is fast passing us. I see this DALI is becoming very common in Mahlakwane, where some doctors are actually having paperless systems. If we use paperless systems, the engineer will be able to put in certain steps within it that without you passing this step, you can't go to the next step. So if you're going to request any form of test, you will be able to be restricted if you didn't put the ID. Because then that ID needs to go and find itself in the patient's file, if you're having a family file. So it's very, very important that we need to maybe start looking at the issue of IT to reduce all this, because I can tell you, every hospital, public sector is worse. Every gate, there is a tent of a particular lawyer, and we always suspect the rest that they are selling the files. That one we know. We know some of them are doing that, but I've said it in this meeting only. Please don't quote me out there. But we are people, medical doctors, professionals are the easiest targets for everyone. Even the nurses now, I mean, you're a GP, someone will come and open a clinic next to you, and they charge 20 times less than the price that they are charging. Hence, I'm saying medical doctors in particular, we are never united, we are the easiest target. Everyone can target us and say, no, I'm going to deal with this one because I know her neighbor is going to be very happy because all the patients are going to move to this person. So, in conclusion, colleagues, I'm saying as laboratory data influences 70% of medical diagnosis, incorrect or incomplete data provided to the laboratory could significantly impact on the success and the overall cost of the treatment of your patient. And I'd like to thank you for your attention and also for staying here for quite some time. We know that sometimes human brain has got this sort of, level of resilience. And I think we need to also thank ourselves for taking over the country where they led us the most. We have lost some of our colleagues, and we need to thank God and Allah and Levadimu Kamabao, we are still surviving, and hope that even tomorrow we still meet. Let's take care of each other and make sure that whatever that is wrong is happening, we correct it, and we keep on supporting each other. Thank you very much. God bless you.
Let us thank the pathologist for taking us through errors that we naturally and normally would commit. Let's raise the roof for them. Do we have any question to ask, or we want to roll it over to tomorrow when there's another speaker from Lancet? Going one. Oh, there's a question at the corner.
Thank you very much, Dr. Mahlakwane, for this wonderful presentation. I'm very interested in what you said about calibration and making sure that things that are happening in labs are verifiable and not done by only technologists. There's been many pop-up labs that came from different minds, particularly during the COVID-19 pandemic, where most of these labs are manned only by technicians and technologists, and they give us results, and usually by SMS, there's nothing printed. What recourse is there in SANA's sphere or in your guys' sphere to make sure that such a thing does not become commonplace? Because right now people don't know what to believe on or in, and because most people who are responsible are actually quiet and saying nothing about it.
Thank you. Let me tell you something. I thought a lot about that issue. I'm from Beresford area, in the Beresford area. And I told them, we cannot be using labs that are not accredited. What happened in COVID? Everyone got clobbered in that area. In 1 week, they moved from 5% to 12%. Dr. Mabuza is here, will tell you. It went high very quickly, because I told them, this is not the accredited lab. Now they took advantage of the emergency medical use. Remember, emergency medical use is not regulated. You can just implement that rule if you're in a crisis like COVID. The same thing in Polokwane. Dr. Masosha was here during the day. The same thing in Polokwane. There was a machine being used by one of the labs called Gene Checker. I complained a lot about it because it's known everywhere. But then because other people want to make sure that they just sweep patients off, one hospital here got infected, majority of the staff members, because of the gene check. Because some of the results are coming out false negative. Now, how do you do a false negative on a DNA test? I mean, this is DNA, we're not talking about potassium or anything. How do you get a false negative on a DNA? It becomes a very big problem. So when you're dealing with genome of an organ, you can't be wrong about it. So I'm now being forwarded to NPG, National Pathology Group, by my practice from the beginning of next year. One of the things that we are going to do is to challenge SANAS and say, SANAS, we need to be able to have standards like SNBS. Right now, remember the Fort Cougar? When it had problems, Fort was nearly in trouble. So we need to come and say, SANAS, go and visit all the branches of health throughout the country. If you find anything being used there that is not being accredited, fine, jail. We need to do that. But we can only do that if we are supported by a group of professionals like yourselves. But if tomorrow I'm going to fight with us one small lab through NPG, but I find that my brother is still using it, it becomes a big problem. It becomes a big problem because some of us doctors are benefiting from it, remember. We put this small tech lab in our offices because they're going to pay rent. So we're eating from with both hands. I'm eating from the rent. Now, if you go to HCSA rules, is not a good clinical practice. If you do that and they catch you, there's trouble. One guy in Mahlakwane had a patient, a pastor came with the wife HIV positive, the pastor HIV negative. Now the pastor is running throughout the country. Come back and says, oh, it means, mommy, when I'm preaching in Zanin or in Beresford or somewhere else, when I'm at home, you do other things because you're HIV positive and I'm HIV negative. Came to our lab, we did a test, we repeated them twice, both of them were negative. Now, what about now the reputation of you as the doctor? So we are going to challenge it and we'll see how we can go. Right now, as I've said, doctors were the weakest link and we are targets of everyone. Until the such time that we stop these things, we are still going to continue to be targets. Even the lawyers that were actually filling their rough forms, they come back and bite us. Thank you.
I would like to share with you a quotation from a British writer, C.S. Lewis, when he says, true humility is not thinking less of yourself. It is when you think of yourself less. Unquote. We thank you for the education. We thank you for the advocacy. And we hope as we move out of this autumn school, we came in the morning with expectation. We now have experience from scholars and tutors like you. Ladies and gentlemen, let's raise the roof for the pathologist. Unless they leave, we give them power for home, not for the road. Right. The very last speaker is Dr. Martin Pakula.